Christina was like trying to get someone to like take it so that she could.
Okay, shall we begin? So just to go back and fill in some gaps on the femoral hernias, I went back and I looked at the big Gray's Anatomy, the one that's like the size of a car. And so here's what's going on. So the femoral sheath does continue on down past the saphenous ring, but of course there is an aperture in it for the great saphenous vein to dive through into its connection with the femoral vein. So that is the aperture through which this hernia can protrude. So an aperture in the femoral sheath as well as in the fascia lata. Does that help clear things up from yesterday?
Can you repeat that again?
Okay, yeah. Today, if I'm not talking loud enough, please let me know. I've got a migraine, so yeah. Well, just keep me talking loud enough you can hear me. Okay, so the femoral hernias, remember they go down through the femoral sheath, and then they can protrude through an opening in the femoral sheath through which the great saphenous vein goes into the femoral sheath. So you've got the femoral sheath here, and this great saphenous vein is diving down through an aperture in it to meet with the femoral vein, right? So it is that aperture in the femoral sheath that the hernia can protrude out of, and then it can also protrude out of the saphenous opening as well.
So it's primarily out of the sheath, but it can go through the...
So it's just, if it makes it out of the sheath, then it could potentially make it out of the saphenous ring as well. When they're protruding out of those apertures, those are when you're going to have the highest degree of potential strangulation. Yes?
So how far down does the femoral sheath go? Because I mean, on the picture it says it seems like it just stops on the...
Right, no, it does continue down further. That's what I read in the big Gray's Anatomy, but they didn't specify exactly how far it went down.
Okay.
I'm assuming it continues down as the adductor canal.
Okay.
Yeah, yes.
In your notes you had it that, I think it was the canal was a continuation of the sheath.
Yes.
And so then it has to go down until they hit that point. And then
Yes. That is, from what I could gather reading yesterday, that is correct, yes. Any other questions? Comments? Okay. So I just wanted to clear that up for us. We'll move on with the lower limb. Okay, so we talked about some of the major features of the proximal end of the femur. I just want to point out a few on the distal portion of the femur that are going to see over and over again, so we just might as well get them in our heads right from the beginning. We've already talked about the lateral condyle here, so this is lateral condyle. This is a posterior view. This is an anterior view. So that's that bulge out on the lateral part of the bone. It is the location of the articular surfaces with the tibia. On the other side, we have the medial condyle here. And then between them, we have the intercondylar fossa. And this is going to be an important location for cruciate ligament attachment. Then the only other one I want you to know is the adductor tubercle. And this is going to be important because some of the big adductor muscles will attach to that site. On the anterior view, we can see again the adductor tubercle here. And then the medial and lateral epicondyles are just surface features of the medial and lateral condyles. So we'll just stick everything on the condyles, and at some point if you need to know whether it's on the main surface of the condyle or on the epicondyle, you can learn later. Okay. So then just a reminder, we've got 3 compartments to the thigh, so we're moving down into the muscular layers. We have the largest compartment is the anterior compartment. And remember, what is the major function of the muscles in the anterior compartment? Knee extension, exactly. Opposite side, we have a smaller posterior compartment, and that is going to function in knee flexion, also some hip extension. And then finally our medial compartment, which is going to be our majorly composed of our adductor muscles. Yeah. Good. And remember, those are all separated by thick bands of fascia. Yep.
For medial is adduction, right?
Adduction. ADD.
ADD.
Adduction. Well, it's not like I didn't try my best to confuse you guys yesterday.
No, I just don't understand why they made it so similar when they did the job.
You gotta love Latin. Gotta love
Yeah.
Latin. Yeah. Okay. Yeah. So this is adduction. There we go. Adduction. Okay. And also a generalization we can remember that we'll come back to again is that typically these compartments are predominantly innervated by a single nerve. Okay. And we will come back to that as we go through the lecture. Okay, so there are two muscles in the anterior compartment of the thigh that do not participate in knee extension. These are our hip flexor muscles. The ones we're quite familiar with, the psoas major and the iliacus or iliacus, depending on who you talk to. And so they both insert onto the lesser trochanter of the femur.
And you said they're on the anterior?
They are considered part of the anterior compartment. And then I'll let you guys go over the innervation and actual origin and insertion sites on your own. I'll post notes with the degree of detail I want you guys to know later after class. Okay. All right, the remainder of the anterior compartment is composed of those knee extensor muscles. The most superficial, as we've been learning in lab, is the rectus femoris, and also the sartorius. And then we want to know the same ones that we know in lab, the vastus lateralis, medialis, and intermedius, which is showing over here. So you should be able to identify them both in this style of diagram and also in this cross-sectional diagram here. And these muscles will all be innervated by what nerve? Femoral nerve. Okay. Move to our medial compartment of the thigh. It's that smaller compartment. We have four muscles I want you to know there. I want you to know the adductor muscles by the name. So the adductor magnus, adductor brevis, and adductor longus. Then also the pectineus. So those four. And the adductor magnus comes down and attaches to that adductor. What's the term? Remember anything when I have a headache? Tubercle on the femur. Mm-hmm.
Is Grissos also part of the?
Yes, thank you. Also the gracilis. And these are all going to be innervated by which nerve, you know?
Still femoral, or is it?
Mm. This
Oh,
is
obturator.
obturator. So the obturator nerve, always the medial compartment of the thigh. Okay, I just wanted to pull off the all the muscles in the medial compartment thigh except for the adductor magnus, just to show a couple of features. So it's attached to the medial portion of the femur, most of the length down from the lesser condyle all the way to the adductor tubercle. And it has these perforations in here and the adductor hiatus. And these are perforations for arteries to flow or to move between the compartments. So we have perforations of the branches of the deep artery of the thigh moving back from the anterior compartment into the posterior compartment. And then we have the adductor hiatus, where the femoral nerve moves posteriorly. And that's the location at which it changes names on us and becomes the popliteal artery. And there's a figure for that later on. Okay, and then finally the posterior compartment. Again, we just want to know the same ones that we're learning in lab. So the biceps femoris, we have the short head and the long head, the biceps femoris. And then the semitendinosus and semimembranosus. And these would be innervated by which nerve, do you think? Yeah, sciatic nerve. And they're all going to function to flex the knee, and some of them will also work to extend the hip joint to a degree. Okay. All right, so we were talking about the arteries diving deep between muscle layers. So remember, all of the arterial supply coming into the lower limb is through the femoral artery. And the femoral artery, of course, is going to begin in the anterior compartment. So it moves down along the anterior compartment here until it passes through that adductor hiatus and goes into the back of the knee. There's a couple of branches I want you to know. I want you to know the profunda femoris artery. This is also the deep artery of the thigh. And that one dives down posteriorly and supplies the posterior part of the anterior compartment, as well as the posterior compartment. Okay. Well, smaller branches of the femoral artery supply the more,
It supplies the posterior part of the anterior compartment
and the posterior compartment, yes. And then the femoral artery supplies that more anterior portion of the anterior compartment. There are also branches that help supply the medial compartment. So we also have the obturator artery that helps supply the medial compartment as well. But I just want you to know profunda femoris, or deep artery of the thigh. Okay, so if we take a layer of muscles off, we can see that deep artery of the thigh running down here between the muscle layers and sending branches posteriorly. And if we turn the leg around. So this is an anterior view, this is a posterior view. If we turn the leg around, we can see those branches of the deep artery of the thigh coming through those apertures in the adductor magnus muscle. It also shows nicely here the adductor hiatus, the femoral artery coming through and becoming the popliteal artery.
So the medial compartment is innervated by what arteries?
It's supplied by some of the deep arteries of the thigh branches.
Of the femoral arteries?
Mm-hmm.
Okay.
Deep artery of the thigh, and then also there's some branches of the obturator artery, but that's higher up typically. Okay. I want you to focus in on the branches of the femoral artery for this section. Okay. Any questions? Okay, so innervation, we've kind of identified the major nerves, and I just wanted to point out some characteristics of each of these. So here we have the femoral nerve moving down into the lower limb. And as soon as it moves past the inguinal ligament, it kind of just explodes and becomes this network of lots of smaller nerves that come up. So what am I looking for? So it's spread out over that anterior compartment of the thigh and innervate those muscles. It is interesting and important to note that it does not pass the knee. So there's no branches lower than the knee.
The femoral nerve does not.
Right.
So then below the knee is the sciatic?
Mm-hmm. Yep, every part of the innervation of the leg and the foot, it comes from the sciatic nerve. Okay, and then again, remember we're innervating anterior compartment. Okay. Here's the obturator nerve coming down to innervate the medial compartment here. And the same story with that. There are no branches below the knee. All of them end at the knee joint. And you also see it's a meshwork of nerve fibers that spreads out and innervates all of those adductor muscles. Okay. And then finally we have the sciatic nerve, and this does start branching out and innervating the posterior compartment of the thigh. And as Emilian commented, it does continue on past the knee as two nerves. It splits into the tibial nerve and the common fibular nerve just before it passes down across the knee joint. So if we have sciatic nerve damage, then we're going to see a lot of weaknesses in the leg and the foot. All right. So then let's move to the knee joint and talk a little bit about its anatomy and how that relates to function. So obviously we've got our major articulation is between the femur and the tibia. There are several ligaments I want to point out that are important in stabilizing that. We have the cruciate ligaments that you guys have been learning, anterior cruciate and posterior cruciate ligaments here. And then we also have the fibular collateral ligament, and on the other side, kind of there-ish, we would have the tibial collateral. ligament, and these also can be what's the word I'm looking for? Identified as the lateral and medial collateral ligaments. So you can refer to them as the tibial and fibular collateral ligaments, or the lateral and medial. So the fibular would be the medial collateral ligament, or the MCL. Tibial would be the lateral collateral ligament. Is that backwards? Yes, I said that backwards, didn't I?
You did.
No, that is correct. Yeah. Yeah, because the fibula is medial to the tibia. And so, yeah.
How is that
No,
lateral
no,
meniscus?
fibula is lateral.
Is it? I'm sorry. My brain's not here today. There we go. There we go. Okay. Okay. That right now? Did I get it straight now? Thank you. I'm not gonna remember anything today, unfortunately. Okay. And then obviously we have our patella and the patellar ligaments on the anterior portion of the knee. Okay. All right, so then in our articulation of the tibia and the femur, there's a couple of things that are important to point out. So the superior surface of the tibia is really flat. They call it the tibial plateau. Here. And you might think, well, what's the point of having a flat surface to a joint? Well, it actually allows for extra stability when the knee joint is extended, because we have a flatter surface of the femoral condyle here. When the joint is extended, that flatter surface is in contact with the articular surface on the tibia, and that provides a little bit wider, more stable surface for standing, so it reduces the muscular activity needed for standing. Then we have a rounder surface here on the posterior portion of the femoral condyles that is in contact with the articular surface of the tibia when the knee is flexed. We also have the menisci. So these articular discs that help provide some contour to the articular surface, but not providing the restriction that an actual curvature of the bone would. So let's move into the menisci. Oh no, I forgot to have this first. So then that flat surface is one of the ways that we stabilize the knee joint when it's extended, to be able to lock that knee joint out and reduce the energy required for standing. We also, remember, have the center of gravity that's anterior to the knee joint to help maintain that extension of the joint. And then as we look at the ligaments, we'll find that they're oriented such that when the knee joint is locked out, there's a slight medial rotation of the femur, which then tightens those ligaments and helps stabilize that joint as well. Any good? Okay, so now we can talk about the menisci. So these are these C-shaped structures. They're made out of fibrocartilage. So tough, resilient structures. They're thicker in the lateral portion here. And thinner as they reach more into the center of the articular surface. And provide that cup shape to help with the articulation between the tibia and the femur. They also act as shock absorption. Because they're very resilient, but yet slightly compressible tissue. Wow. Okay. Those are the menisci. Okay. Here are a couple of images of the menisci. So you can see here the wedge-shaped that they have, here thinner towards the center of the articular surface, thicker towards the edges, providing that stability. This is our medial meniscus, and then lateral meniscus looks much the same, slightly different shape, but again, that wedge-shaped structure here for the lateral meniscus. All right, so ligaments of the knee. So we kind of did an overview. Let's talk about them a little bit more in detail. So here we have our fibular collateral ligament here. Also the LCL, running from the lateral portion of the femur down to an attachment point on the fibula. And then on the other side, our tibial collateral ligament, the medial portion of the femur to the tibia, attaches there. Also important to note, it attaches to the medial meniscus. And it creates a more continual never mind, I don't even know what I was going to say. Okay, so those, purpose of those, what would be the main purpose of our collateral ligaments? Yeah, so we're going to prevent what kind of motion? Yeah, we're going to prevent lateral movement of the knee joint. So then if we tear one, we're going to get the knee moving out towards that torn side. Okay, so then our other ligaments, the cruciate ligaments. So the anterior cruciate ligament and posterior cruciate ligament. These attach inside the intercondylar fossa of the femur, and then on the tibia the anterior cruciate ligament attaches to the anterior portion of the tibial plateau, and the posterior cruciate ligament attaches posterior to that. So the anterior cruciate ligament, what is its job going to be? What is it going to prevent? Yep, so forward movement of the tibia based on on a fixed femur. And then the posterior cruciate ligament is going to prevent posterior displacement of the tibia, so posterior movement. And you'll test this by using the anterior and posterior drawer tests. So you'd have the patient sit with their knee at a 90-degree angle, and then you would either pull or push on the tibia while fixing the femur and see if that tibia would slide forward or backwards more than it wouldn't on the non-injured limb. So if the anterior cruciate ligament is torn, if you pull on the tibia, then that would slide, the joint would slide forward to an exaggerated degree, an extra centimeter or so. Whereas if you have a torn posterior cruciate ligament, if you push that, the tibia back in relation to the femur, you'd feel actual some gliding movement backwards compared to the stable joint. And so they say it feels slightly like sliding a drawer in and out, which is where it gets its name of drawer test. So I'm sure you will hit this in your HCPCS class at some point if you haven't already. My brother actually tried that out on me. He's in medical school, and he was like, "Can we test your knee?" And so now I was like, "Oh, that's what he was doing." Okay, so then all these ligaments stabilizing the knee joints can often get injured by flexion or overextension of the knee joint, or lateral pushing the joint laterally. And there's a particular triad of injuries that tends to happen together, especially when the foot is fixed and you have a twisting torsion type movement of the body. So the femur is twisting and moving laterally in relation to a fixed foot. And the three structures that get torn together are the anterior cruciate ligament, the tibial collateral ligament, and the medial meniscus. All get ripped together very typically, and they call this the unhappy triad of knee injuries. They very commonly happen together. So obviously they're an example of football, that's a good one. Also the other sort of football, so soccer, those are common injuries in any joint, any sport where you're going to have excessive forces placed on the knee joint. Okay. All right, so those are ligaments, and the articular surfaces, the major bony structures. So then we have the synovial membrane enclosing the joint cavity. So we have it covering the articular surfaces of the two joints. And then we have an extra recess of that synovial membrane coming up into the suprapatellar bursa. And remember, bursa can be this recess of the synovial membrane. They also can have isolated pockets of synovial membrane filled with the synovial fluid. These are the rest of the bursa. And they form in areas where there's lots of friction, so increased in high friction areas. And you can actually form new bursa if you change your running style and start putting more friction on a new region of the joint. You actually can have a new bursa develop in that region. So most people have quite a few bursa in the knee. There are a few that are common in most people. So the prepatellar bursa and the subcutaneous and deep infrapatellar bursa and the suprapatellar bursa. Those three, or four rather, are common in most people. Okay. So the prepatellar bursa lies on top of the patella and allows for smooth movement of the skin over the surface of the patella. And then the infrapatellar bursae allow for smooth movement of structures past that patellar ligament. Okay. Make sense? No question? Okay. All right, so then we have the rest of the joint capsule. I'm not going to really worry about too much for you guys. There's a lot of little ligaments in there. But I do want to point out one muscle that's very closely associated with the joint capsule in the knee. And this is the popliteus muscle. And it wraps around the posterior part of the knee here. And it has a very specific function, very specialized function. So when the knee is fully extended, your hamstrings are actually pretty weak and don't have the ability to actually begin flexion of the knee. So this is our kickstarter for knee flexion. So it initiates the knee flexion until the hamstring muscles, the posterior compartment of the thigh, can take over that. Yeah. Okay. All right, so then arteries contributing to the blood supply of the knee. One nice thing they did with naming these arteries is they're mostly just termed according to their spatial arrangement around the knee joint. All of them are called genicular arteries. This is just a term referring to the knee, so genicular. So we have the superior lateral genicular artery and the superior medial genicular artery, superior to the knee joint. And then we have the inferior lateral and inferior medial genicular arteries coming up from the inferior and taking care of the inferior portion of the knee joint. These are obviously going to be all branches of the femoral artery and the popliteal artery. Okay. So that at least is a little easier than some of the arteries we've learned. Names actually make sense.
So are the superior coming from the femoral and the inferior coming from the popliteal?
Mm-hmm. Basically, yes. Okay. All right. Okay, so then, in relation to the knee joint, I want to talk about a couple of terms that are important to know. And these have to do with alignment of the joint and then the potential consequences of these alignments. So typically, yesterday, I think, we talked about the offset of the femur from vertical, so it's about a 7-degree angle. This angle is called the Q angle. So it's normally about 7 degrees. And that allows for perfect alignment of the articular facets of the knee joint, so you get equal weight distribution on the lateral condyle and the medial condyles of the femur in their articulation with the tibia. So that allows for even weight distribution, even wear and tear. Some individuals have a reduced Q angle, so it's going to be less than 7 degrees. The femur is going to be more straight up and down. This is actually going to put the majority of the pressure on the medial half of the knee joint. And in some severe instances can completely allow for no contact on the lateral portion of the knee joint. This is what we call genu varum, otherwise known as bow-leggedness.
Can you explain real quickly one more time the normal alignment, like what that does? Is that just because you said the flat surfaces are touching?
Right, so you have equal weight distribution on the lateral and the medial portions of the knee joint. So you remember you've got your lateral and medial femoral condyles, two separate things, so there's equal weight distribution on those two condyles. Whereas with genu varum, we have increased weight bearing on the medial condyle and less or no weight bearing on the lateral condyle. Okay. The other version is genu valgum, and this is like knock-kneedness, and so we have the opposite problem, an increased Q angle. So the femur has a greater degree of slope away from vertical, and this places the majority of the weight on the lateral condyle, the lateral portion of the tibia. And So then you're going to get increased wear and tear on the lateral portion of that joint. And so then the consequence is typically osteoarthritis developing in the portion of the joint that has the greater degree of weight bearing. Okay. Make sense? Any questions?
Can that be corrected?
That's a good question.
It can be like a total knee replacement.
You can do a total knee replacement?
Yeah, a lot of times, like, the x-rays always show this, like, you would see one side collapse and then your meniscus would be gone, and you could see the osteoarthritis on it, and so that's a key example for a total knee.
Okay, well then, one question I had when I was prepping this, kind of related to yours, Becky, is would then that still set up the imbalance of weight? Because typically the problem is higher up, you know, if there's an increase. So
Usually
would,
they're not countering that aspect of it. Sometimes they can make their cuts, because they're gonna cut both the femur and the tibia.
Yeah.
In the process, and sometimes their cuts, they can help align a little bit, but they don't wanna do too much, because then you're gonna start creating head pain.
right.
And so a lot of times they go with their natural areas, and then just the new surface can wear and handle it.
Good to know.
Probably braces on kids.
I guess that would depend on whether it's a developed problem or a congenital problem. Because if, like, congenitally the neck of your femur is rotated a lot more, then that would be harder to fix. If it's a problem with weakness of a muscle group or ligaments overstretching, then maybe that would help. Yeah, Carissa?
You actually with like the B, you would do a tibial osteotomy.
Okay.
To shorten it.
Oh, okay.
And then it actually makes a knee replacement more difficult to do.
Okay.
Because you have to worry about that. I only know this because my dad had a tibial osteotomy because he was bow-legged and now he's doing
Oh.
a knee replacement.
So they actually, like, go in and cut
Yeah, they cut.
the tibia like this so it lines up better?
Yeah, and then they go in and they put like screws in there.
Oh,
But then it makes the knee replacement more difficult.
Right.
Because those screws, they're kind of in the way. You can't really take them out because they have big chunks of.
Right, you'd have to actually replace that whole head of the tibia.
Yeah. Yeah.
Wow.
So it makes
Well,
it
that's
more
really
difficult.
interesting. Cool.
Yeah.
I learned something today. I like this. Cool, all right. Well, we'll see you in lab tomorrow. Hopefully I'm a more functional person by then.
Oh,